Well, hello again and welcome. My name is Michael Boniface, and I'm the Director of Emergency Ultrasound in the Department of Emergency Medicine at Mayo Clinic, Florida. Today we're going to be going over a brief introduction to a staple of point-of-care ultrasound. In fact, this was one of the very first widely adopted applications of bedside sonography, the FAST examination. FAST stands for Focused Assessment Using Sonography in Trauma. But as you'll see, despite its original application for trauma patients, the concept behind the FAST examination can be applied to a much broader population of patients in a variety of clinical settings. The E, prior to the FAST examination, designates an extended FAST exam, looking at thoracic windows in addition to its originally described windows. So I'd like to get started by showing you this photograph. This is a Toyota Prius C, the smallest of the expanded line of Priuses. This puppy sports a whopping 99 horsepower and can go from 0 to 60 in about 10.9 seconds. It was also one of the few cars awarded 1 out of 5 stars by Car and Driver magazine. So you see where I'm going with this. The reason I'm showing this to you is because this car is the car that my mother-in-law was driving 2 years ago when she was T-boned by a Ford F-350 making a left turn in South Florida. She's fine now, but she was airlifted at the time, brought to the local trauma facility, and you can believe she had a FAST exam when she got there. Fortunately, she didn't have any serious bleeding at the time and did well, but this is a very, very common clinical example of when having the ultrasound at the ready can make huge management decisions in the patients you're caring for. Today, our goals and objectives are going to be as follows. We're going to talk a little bit about the indications and the utility of the FAST examination, the different imaging windows and acquisition techniques, normal anatomy, and some pathological examples. So this is your typical trauma or resuscitation bay. You have a large space to accommodate all your staff, easily accessible supplies, and most importantly, your easily accessible bedside ultrasound. So what is the purpose of the FAST examination? Fundamentally, the purpose of the FAST examination is to detect free fluid in the intraperitoneal, intrathoracic, and in the pericardial spaces. This examination has been around since the 1980s, where it was originally required by the German surgical boards in 1988. It was incorporated into the algorithm for the Advanced Trauma Life Support course in 1997, and since 2001 has been required for residency training in emergency medicine. It's endorsed by multiple professional societies, not only that of emergency medicine, but also those of trauma surgery, the American Institute of Ultrasound in Medicine, the Society for Critical Care Medicine, and believe it or not, the American College of Radiology says that this is something that's appropriate for clinicians to be doing at the bedside in the appropriate clinical setting. What did they used to do before the FAST examination? Well, it was a procedure called diagnostic peritoneal lavage, and it would involve basically cutting a small hole with a scalpel in the patient's anterior abdominal wall, infusing about 1 liter of normal saline or other crystalloid, sloshing things around a little bit, and seeing if the effluent they got back out was bloody or not. There was some criteria that was about 200,000 red blood cells per high-powered field, but more commonly, if the effluent could be looked at and you couldn't read a newspaper behind it, it was considered positive. Now, this was an extraordinarily sensitive means of detecting blood because I think it would pick up as little as 20 cc's of blood in the 1 liter of fluid you put in there, but you can imagine that it was too sensitive. This led to a tremendous number of non-therapeutic laparotomies. And especially as the management of solid organ injuries changed to be much more conservative and non-operative, the utility of this was really not warranted. Okay, so you might be asking yourself, hey, I'm not a trauma surgeon, I'm not an emergency medicine physician, why do I need to care about the FAST examination? Well, yes, it's true that it was originally developed for the evaluation of patients with blunt or penetrating torso trauma. But it's also equally useful in patients with abdominal pain and undifferentiated hypotension, in patients during the immediate post-CPR period or during an active code, if you have time to take a look, and in women of childbearing age presenting with, well, essentially anything, because they could always have an ectopic pregnancy. Other common reasons are for post-operative hemorrhage for your patients who have a change in clinical status on the floor. Colonoscopy is actually one of the most common reasons of non-traumatic splenic rupture, so you'd be surprised how often it can be useful for the patients you're taking care of. So what do we know about the FAST examination? We know that it's extremely sensitive and specific for the detection of free intraperitoneal fluid, and depending on the literature you're looking at, it can pick up as little as about 200 cc's of free fluid. We also know with the extended FAST examination that it's far superior with regards to its sensitivity for detecting pneumothorax. with a sensitivity approaching 98% compared to about 75% for a single AP radiograph in the supine trauma patient. But why do we like fast examination? Well, because it's fast. It should be done in about 2 minutes or less. It's non-invasive as opposed to the diagnostic peritoneal lavage. It's repeatable so that if there's a change in your patient's clinical status, you can go back and do it again. And it's portable. There's an old adage that death begins in radiology, which is not so much an issue now, as our CT scanners are located very close to where we take care of our patients. But in older hospitals, or if your patient is in the ICU and something changes, you sometimes have to transport them off the floor. And when things go south, they go south very quickly when they're not in the appropriate care setting. What are some other things that we know about the data-driven evidence behind fast examination? Well, we know that it will decrease the time to diagnosis and the time to the operating room. It decreases cost and resource utilization substantially as a result of this. In some settings, it will actually improve survival and neurological outcomes, and that by having a positive fast examination will increase your chance of going to the operating room for a therapeutic laparotomy 116-fold. So here is an old Gray's Anatomy drawing of the peritoneum, just showing you that there are predictable ways in which the peritoneal reflections allow fluid to travel where the bleeding comes from. Now, I should mention here that while the fast examination is extremely sensitive for the detection of intraperitoneal fluid, it does not reliably detect retroperitoneal fluid. Okay? Retroperitoneal fluid you can commonly see for injuries in the pelvis, following left heart catheterization when you develop retroperitoneal hematomas. Rupturing abdominal aortic aneurysms will sometimes hemorrhage only retroperitoneally. So there are certain things you need to be careful about, that just because you have a negative fast examination doesn't mean the patient isn't bleeding. It just means they're not bleeding a significant volume into their peritoneum. Okay, so again, who needs a fast examination? Well, this guy needs an EFAST examination. So this is a gentleman that I had the pleasure of taking care of when I did my residency training in North Carolina. He was celebrating his birthday when his buddy decided to throw this projectile at him. This is called a frog gigger, for those who are not familiar with it, and it's a homemade device used to gig frogs. But we didn't know at the time whether this entered his thoracic cavity or not. So the ultrasound allowed us to rapidly detect whether there was any pneumothorax, hemothorax, or any free fluid in the pericardial space, which would put him at great risk for developing cardiac tamponade. Now, I noticed that this looked a lot like a trident, so all I could think about was the movie Anchorman, where Steve Carell's character, Brick, got a trident when the news media outlets were fighting amongst each other. So, what is free fluid when we see it on the ultrasound? Well, we know it's anechoic, meaning there are no echoes, it's totally black. It is dependent, meaning that it will go to very predictable spaces within these peritoneal reflections, and it has very sharp angles. Now, one thing I should mention as well is while most fresh blood or free fluid is totally anechoic, you can start to see clot developing for fluid that's been there for a while, and that will have some internal echoes with it. Well, let me show you an example of what this looks like in a positive fast examination. Here we can see that the free fluid in Morrison's pouch of the right upper quadrant is totally black inside. It tapers down into this fine point in the most dependent area as it approaches the spine posteriorly. Now, when you're going to do your fast examination, what transducer do you want to pick up off your cart? Well, either of these are appropriate, the phased array or the curvilinear. They both operate at relatively low frequencies, which will allow you to see at greater depths into the abdominal cavity, which, again, in the southeast is really important. Now, for the thoracic windows, if time permits, the high-frequency linear transducer is going to be a better bet. So the 5 imaging windows that you need for the fast examination include the subxiphoid or subcostal view of the heart, the right upper quadrant, the left upper quadrant, the pelvis, and then your anterior thoracic windows. So I'm going to briefly go through and show you what this will look like. In the subcostal or subxiphoid view of the heart, it'll produce an image that looks a little bit like this, where the very first thing you see is the liver, followed by the diaphragm, and then the right ventricle of the heart. In the right upper quadrant, you're going to get an image produced in a semi-coronal fashion, sort of like this. Similarly, in the left upper quadrant, your image will appear just like this, except your probe needs to be positioned a little bit more cephalad and a little bit more posterior. In the pelvic windows, either an axial or sagittal image is fine. I like to do both, because depending on your anatomy, it's easier to see one way versus the other. In the sagittal example here, it'll produce an image like this. and your anterior thoracic windows will produce an image that looks a little something like this. I'm going to show you a quick example now of what the subcostal or subxiphoid view of the heart is going to look like. So it'll produce an image just like this, and remember, you're looking from below the heart through the liver and into the bottom side of the heart. So what you'll see first is the liver, then the right ventricle, left ventricle, and their corresponding atria. The most fluid-dependent portion here is going to be between the right ventricle free wall and the diaphragm in this first red line representing the pericardium. Now, in some patients who have a very protuberant abdomen or if they're having a great deal of pain, you might not be able to get this image quite good enough, and that's okay. Just go to a quick parasternal long view. That will produce an image that looks a little bit like this: your right ventricle, left atrium, and aorta. But remember that in this case, since you're looking from above the heart, the most dependent portion where fluid is going to accumulate is actually in the bottom of your screen, between the free wall of the left ventricle and the pericardium. So a little bit more on normal anatomy with the pericardial view here. You can do it, as I mentioned, subxiphoid or subcostal. You're using your liver as an acoustic window. You want to flatten the probe and point it towards the left nipple. If you need to, instruct the patient to take a big breath and hold it, and then you want to fan a little bit to inspect the anterior and posterior pericardial space. So here's an example of what this is going to look like in real time. This is with a curvilinear probe, and we can see our right ventricle, left ventricle, all of that moving quite well. The bright white pericardia has no pericardial fluid. You do need to be careful sometimes because particularly in a parasternal window, you can see an apical fat pad. Now the way you'll tell this and differentiate it from free fluid is that it typically has some internal echoes and will usually move fixed with the wall of the ventricle. Right upper quadrant space, there's going to be three distinct areas that we want to look at. We want to look at the hepatorenal space, which is otherwise known as Morrison's pouch. This is the potential space that exists between the Glisson's capsule of the liver and Gerota's fascia of the kidney. We then want to slide our probe cephalad to inspect the diaphragm above and below for the pleural space, and we want to slide our probe caudally to inspect the other potential space referred to as the pericolic gutter. While we're doing this, we want to fan our probe anteriorly and posteriorly the entire way to make sure we're not missing the fluid. So here are those spaces I'm talking about. So this bright white line between the kidney and the liver is the potential space of Morrison's pouch. Also recognize that you see the spine, which is the bright white line going like this underneath the kidney and the liver, and it stops at the diaphragm. It does not continue on. That's really important because in pathological states, such as hemothorax or pleural effusion, you will see this spine line continue on beyond the diaphragm into the thorax. The reason it stops is because normal aerated lung tissue will scatter all of our sound waves and we don't see anything behind the lung. It becomes invisible to us. So we want to inspect for the spine line and make sure it terminates at the diaphragm. We want to inspect Morrison's pouch, and we want to inspect the pericolic gutter, which is designated by this circle. Remember that everything in this shaded area here is going to represent retroperitoneum. So to go about acquiring your image for the right upper quadrant, we're going to take our transducer, begin in a coronal fashion, and rotate the probe a little bit counterclockwise to try to sneak in between the rib spaces to eliminate those shadows, and it will produce an image something like this. Now again, I'm fanning through the kidney anteriorly and posteriorly because a thin slice of free fluid could appear in Morrison's pouch at any of those levels. When I've seen the FAST exam fail, I've seen it fail because the operator will put the probe on the patient in a single plane, take a quick look, and say, FAST negative. But if they had simply fanned through a little bit more posteriorly, they would see that thin slice of free fluid representing blood in Morrison's pouch. So again, three areas that we need to look at here in the right upper quadrant. Morrison's pouch, that bright white hyperechoic potential space between the kidney and the liver. Slide the probe up and evaluate the diaphragm above and below, and we can see that spine line stop and terminate at the diaphragm. And then fan your probe all the way down here to the potential space of the pericolic gutter, which you will typically see around the inferior pole of the kidney, sitting on top of the psoas muscle there. Moving on to the left upper quadrant view, this is going to be very similar, except that you're going to have to look a little bit more cephalad and a little bit more posterior. You want to evaluate the splenorenal recess, which is the area similar to Morrison's pouch between the kidney and the spleen, the pleural space, and the pericolic gutter, again fanning anteriorly and posteriorly the entire way. Now, one thing that I should mention about the left side here is usually the injury patterns or ways of bleeding that we'll see on this side, it is actually more common for blood to accumulate above the spleen in the subphrenic space between the spleen and the diaphragm rather than between the spleen and the kidney itself. But again, 3 areas we're going to look at. The potential space between these, slide our probe up to the diaphragm, inspect the spine line, make sure it stops, make sure there's no free fluid in the thorax, slide the probe down towards the feet, and inspect that paracolic gutter. One pitfall to mention briefly about the left upper quadrant is that you can sometimes be fooled into thinking that there is free fluid when looking at a fluid-filled and distended stomach fundus that can sometimes be seen adjacent to the spleen and the kidney. Now, this will typically differentiate itself from free fluid because there'll be bits and pieces of food particles or gas and air bubbles floating around, so with time and experience, it'll be easier to tell those apart. Talk a little bit about the pelvic windows now. It's best seen through a full bladder, and you'll find free fluid adjacent to it either on the left or right side or anterior and posterior, depending on where it's coming from. In men, the most dependent portion of the pelvis is the rectovesical space, below the bladder and between that and the rectum, and in women it's going to be in the pouch of Douglas, which is below the uterus and cervix. You want to look in an axial and a sagittal plane, fanning through in its entirety, as seen in this subsequent example. So this is an axial view of the bladder. You can see I'm fanning posteriorly, and then I'm fanning anteriorly until I visualize the bladder in its entirety and get the tip of the fundus of the uterus there. I'll turn my probe 90 degrees now for a sagittal look, and I see that nice anteverted uterus coming up right there. We're going to be looking for free fluid in the pouch of Douglas, which is going to be posterior to the most dependent portion of the uterus and cervix down there. And in this example, it is negative. Moving on to the anterior thoracic windows, if time permits, you want to switch to the high-frequency linear transducer. I like to look in a sagittal plane just below the clavicle, but really you're going to want to look into whatever the highest point is, because remember, air rises as high as it can go. That's going to be different depending on the patient's anatomy of their thoracic cage. And it's okay to look in several different places just to be absolutely sure. What we're looking for here is pleural sliding. If you can't tell just by the B-mode images, sometimes M-mode is helpful. And when you see a lung point, which is the pleural sliding coming in and out of a view, that is where the 2 layers of the pleura actually peel off of each other from the air between them. And that's very, very specific for pneumothorax. So this is what a normal high-frequency linear transducer will give you of normal lung sliding. From top to bottom there, we have skin, soft tissue, intercostal muscles. We see on the right side a rib that's bright white and hyperechoic, casting a shadow, and a bright white horizontal line just below that, representing the 2 layers of the pleura, which in normal aerated lung are opposed to each other. And you can see them actually sliding back and forth as the patient breathes in. Sometimes it's referred to as like ants marching on a log, and you'll cast little tiny comet tails beneath it. But again, if you can't tell for sure that this is lung sliding by looking at it in B mode, switch to M mode, and it will give you an image that looks something like this. We refer to this as the sandy beach or sandy shore sign, and again, M mode represents a one-dimensional slice and how structures passing through that one dimension move over time. Well, from skin down to the pleura, there is absolutely no movement at all. They're fixed structures, so that will be represented by solid horizontal lines. Now, once you get to the pleura, because it's sliding with inspiration, it's going to kind of scatter all of those sound waves beneath it, and you'll get a little more granular appearance. And, it's called the sandy beach sign because if you look at this a little bit, you can imagine waves crashing into the sand of the beach. Now, what does this look like in a pneumothorax? Well, in a pneumothorax, there's going to be no pleural sliding because by the time you get to your parietal pleura, there's a layer of air before you get to your visceral pleura. So that, again, is going to scatter everything, but you're not going to see any motion. So in M mode, it will look like solid horizontal lines the entire way across the screen. That's also known as the barcode or stratosphere sign. So this is an example, again, of normal aerated lung with the 2D image superimposed next to the M mode image. All right, let's get to some pathological examples. So in this first example here, we've got a subcostal view of the heart, and what do we see is free fluid, right? And actually a large amount of free fluid because we see it wrapping all the way around the apex. And what's more than that, we see collapse of the right ventricle. So this patient is in tamponade. From whatever reason, he's got that free fluid or bleeding in his pericardial space 4. We can see that right ventricle collapsing, left ventricle, right atrium, left atrium, and this is the free fluid here designated by the arrows. Same patient here in a parasternal long view will appear like this. We can see now that most of the fluid is visible on the bottom portion between the pericardium and the free wall of the left ventricle, as described earlier. And our chambers here, the right ventricle, where it's not completely collapsing here, but we can tell that there's some paradoxical motion of the right free wall. And again, free fluid seen on either side of the heart there. Okay, a couple examples of the right upper quadrant now that are positive. Let's start by looking at this image right here, which, by all accounts, looks pretty normal. I don't really see much in the way of free fluid, do you? Well, let's see what happens if we fan our probe just a little bit posteriorly on that same patient. That's a lot harder to miss. You can see why it's so important to look all the way anteriorly and all the way posteriorly rather than just evaluating through a single plane. As we see this video example here, as I'm fanning up and down, you can see there is a lot of fluid posterior to the liver there. In a single plane, it might even be fooled to look like it's the inferior vena cava, but you can see that it does not go through the diaphragm. So again, an important reason to evaluate the entire target area that you're looking at. Some additional examples. Free fluid seen here in Morrison's pouch. Liver, kidney, diaphragm are free fluid. One more example. Again, you can see as I'm fanning posteriorly, it maintains that very sharp edge there that you'll see with free fluid. Another example, which again is very easy to miss here, just a nice thin stripe of free fluid in Morrison's pouch. Okay, let's look at one more example here. I think everybody can see that there's a pretty clear amount of free fluid, large amount of black stuff right near the liver, but is this truly intraperitoneal fluid? Well, what if I were to tell you that this is a hemothorax? This represents free intrathoracic fluid. Now, how can we tell that? Well, remember what I mentioned earlier about the spine line? We see it go along, and rather than terminating at the diaphragm or the dome of the liver there, it continues on into the thorax. And it does that because free fluid in the pleural space is allowing our sound waves to travel through it and see what's behind. Free fluid right there, and continuation of the spine line. All right, let's turn our attention now to the left upper quadrant here. You can see there's a fairly similar appearance of a black stripe of free fluid between the spleen and the kidney. But what about this example here in the next slide? So here I can kind of make out the kidney, I can make out the spleen, but do we see any free fluid? Well, this one's a lot harder to tell. What if I were to tell you that this is a positive FAST examination, but rather than free anechoic fluid, we've actually got some free fluid that's been sitting for a little bit and starting to develop clot. Now, I took care of a patient about a year ago in our emergency department here who was having a hemorrhage from a cystic artery bleed a couple of days after a routine elective cholecystectomy, and I could actually see the blood clotting every 10 minutes as I was doing the subsequent examination, like right before my eyes. Here's another example of the bleeding patterns that we can see in the left upper quadrant. In this area, rather than in the space between the spleen and the kidney, we see a greater amount of accumulation of fluid in that subphrenic space between the spleen and the diaphragm. Moving on to the pelvic windows. So here we can see a sagittal view of the bladder with a little stripe of free fluid anterior to that bladder dome. Here, in this axial view of the pelvis, we see what's called the double bubble or double bladder sign. So I can't tell for sure which one of these is bladder and which one is free fluid, but it doesn't matter, right? You shouldn't have two bladders. One of them is going to be free fluid. Moving on to the anterior thoracic windows, we see no lung sliding here, as demonstrated on M mode with the stratosphere or barcode sign. Okay, let's talk a little bit about some of the diagnostic algorithms or decision-making pathways that can be used using the FAST examination. So in a trauma patient, when we have a FAST examination that's positive, and that patient is hemodynamically or clinically unstable, they need to go to the operating room right now. Do not pause for additional diagnostics, don't go to CAT scan, they need a laparotomy. Now, if that patient has a positive FAST examination but they are stable, consider in the appropriate care setting getting additional information with something like a CT scan because they may be a candidate for non-operative or conservative management. Maybe they need something embolized by interventional radiology rather than a trauma XLAP. Now, in a patient that has a FAST that's negative and they are still hemodynamically unstable, well, this is what you get paid the big bucks for. Something else is going on that is not peritoneal hemorrhage. And we'll talk about the differential of that in the next slide. If the patient is stable and their FAST is negative, well, treat them as you otherwise would. Maybe they just need some observation for a little bit and repeat the FAST exam in 2 to 3 hours. Maybe they can go home right now. Clearly, when we have somebody with a positive FAST examination that's hemodynamically unstable, well, they're going to have a tamponade, peritoneal hemorrhage, a tension pneumothorax, hemothorax, something that you can see on the FAST examination. But when they're unstable and your FAST exam is negative, consider these additional causes. Maybe it's hemorrhage externally from something that you might have missed, like a scalp laceration. Maybe they're bleeding into different compartments, like the thighs. Maybe they've got a traumatic aortic dissection or rupture, pelvic fracture, other cause of retroperitoneal hemorrhage that's not going to be detectable on FAST examination. Maybe this is neurogenic shock, or maybe they have concomitant severe heart failure and you need to take a better medical history. One thing I want to talk about briefly that we use our FAST examination for, more specifically the cardiac view, is your post-arrest assessment. In addition to being able to identify potentially reversible causes, such as pericardial fluid resulting in tamponade, you can also use it to help prognosticate what's going to happen during a code situation. So take a look at this video clip and think about what you see going on. Not a lot of anything, right? So this is cardiac standstill that's being taken in between compressions during a pulse check. Now you can see something happen. You can see some blood moving in the right ventricular chamber. You might even be able to see a little flicker of the mitral valve, but none of the cardiac muscle itself is moving. So what does cardiac standstill tell us about survivability during cardiac arrest? Well, this is something that's been asked over the last 15 to 20 years in some very small original studies comparing patients who have cardiac activity compared to patients that don't. There is a significant difference in the overall survival to hospital discharge. I think one patient survived in this series. In another series performed that same year, there were 0 patients that walked out of the hospital who had cardiac standstill during arrest. But our most robust data set now comes from the REASON trial, which was just published in Resuscitation this past September. Now, I remember enrolling patients in residency for this trial, and it really has a great amount of data among several clinical sites. So they enrolled almost 800 patients, and only 7% of patients without cardiac activity survived to hospital admission, compared to almost 29%, and only 1 out of every 200 patients without cardiac activity survived to hospital discharge, versus about 4%. Now, what's also interesting to know with this data set is that survival discharge was as high as 15% in the population of patients who underwent pericardiocentesis when a pericardial effusion was seen on bedside ultrasound. So something to consider if you're in an active code situation and you have an ultrasound available to you. Take a quick look before you decide what to do next. And with that, any other questions, feel free to email me. I've included the list of references here that were mentioned in the lecture earlier. And I thank you for your time, appreciate it, and go forth and continue to ultrasound.